Thanks so much, Caroline, for the lovely introduction. And as Caroline mentioned, so Ella Prendergast is my name, and I'm the clinical nurse specialist that works with 3M KCI, and I focus on the negative pressure wound therapy portfolio with them. So today what we're going to do is we're going to focus on an overview of wound healing and chronic wounds. And then at the end, we're just going to go through the use of SNAP negative pressure wound therapy. So it's a new disposable negative pressure wound therapy device, which is available to people in the community now. So that's what we're going to go through today. So the next slide there, the agenda. So we're going to define what a wound is and a chronic wound. We'll talk about the biology of wound healing. Then we'll focus on a compromised patient and why there's other things that are going on in patients except the wound, as well as the wound, should I say, which will compromise the wound healing. Then we'll focus on wound assessment and the time tool for assessing the wounds. And then we'll mention our SNAP therapy system. So first up then, what is a wound? So a wound is described as a defect or a break in the skin that results from physical, mechanical or thermal damage, or that develops as a result of an underlying medical or physiological disorder. Okay, so that's quite lengthy. So acute wounds progress through the healing phase in an organized, progressive and timely manner. So they don't get stuck, they progress from one phase to the next stage. So an example of an acute wound then would be your traumatic wounds or your surgically induced wounds, so your post-operative wounds. So then what is a chronic wound? So chronic wounds are defined as wounds that fail to proceed through the normal phases of wound healing in an orderly and timely manner. So chronic wounds fail to progress through the normal progressive sequence of tissue repair, and they fail to resume normal cellular activity. So the protracted course of repair may arise due to the presence of comorbidities in a patient, prolonged inflammation or infection in a wound, maybe the patient is malnourished, or maybe they have an impaired immune response. So examples of chronic wounds then is any wound that hasn't healed in a normal fashion, so would be your leg ulcers, your diabetic foot ulcers and pressure ulcers, just as an example. So then how do we heal our wounds? So the mechanism by which a wound will heal can be categorized into a number of different categories. So the first one is primary closure, and that's also known as primary intention. So that means the edges of the wounds are approximated or brought together by mechanical means. So this would be your post-op wounds, they're closed with sutures or staples. So next up then we have the delayed primary closure. So this would be when a wound needs to be delayed for 3 to 6 days. Perhaps there is infection there, the wound is contaminated, or there's impaired perfusion. So they leave it a couple of days and then they'll go back and they'll have their primary closure on their wound. Thirdly, then we have the secondary closure. So the other name for this is secondary intention. So this would be when wounds have extensive tissue loss, for example, trauma in burns patients or in ulcers, where they're unsuitable for primary closure. So there's not enough tissue there to close the wound by primary intention. So these wounds are left open to heal by granulation tissue, to heal by contraction, and to get that epithelialization over the top of the wound. And then two other ways then is a skin graft and a flap. So a skin graft would be partial or full thickness of the epidermis and the dermis in the skin, but it wouldn't bring the blood supply, and they'd place that over the wound to cover the wound. And then with a flap, they do the exact same thing, except they bring the blood supply with it to that wound. If there was an extensive defect, they'd do a flap. Okay, so phases of wound healing. So there's 4 different phases of wound healing, and now you could talk about this all day. So we'll try and make it as small as we can. So there's 4 different phases. We have the hemostasis phase, then we have the inflammatory phase, then we have the proliferative phase and the maturation phase, which is otherwise known as the remodeling stage. So all the stages of wound healing are linear, so the wounds can progress backwards or forwards depending on what's going on in that wound and what is happening with the external factors in the patient as well. So the first phase is the hemostasis phase. So this phase is basically the clotting of the wound. So it starts when the blood leaks out of the body, and the first step is when the blood vessels constrict and they restrict the blood flow. So then the platelets stick together in order to seal the break in the wall of that blood vessel. And then finally what happens is coagulation occurs and you get a platelet plug in that wound. So that happens very quick. It happens within seconds, and you get your platelets formating within about 60 seconds. Okay, so it's a very quick phase. Next up then we have the inflammatory phase. So inflammation is the second phase, and it begins straight away after the injury when the injured blood vessels leak fluid, and this causes localized swelling around the wound. So the inflammation both controls the bleeding and it prevents the infection. So this fluid engorgement then allows the healing and repair cells. So these would be your white blood cells which should migrate to your wound, and they allow them to move to the site of the wound. And these white blood cells, they eat up all the damaged cells, the pathogens and the bacteria that we don't want in that wound. And what else they do is because they're eating up all this bad bacteria that is in the wound, as well as the growth factors and nutrients and everything else that's going on, it creates a swelling in the wound, and you get heat and you get pain and you get redness as well. So these would be common signs that you'd look out for in infection as well. So there's a big overlap between inflammation and infection. So inflammation is a natural part of the wound healing, but it can be very problematic if it is prolonged or excessive. So if you get a late stage of inflammation and it's prolonged in patients, it can be very problematic. And this often happens with chronic wounds. They cannot progress from this stage onto the next stage. So the third stage then is the proliferative phase. So the proliferative phase is when the wound is rebuilt with new tissue. So it's made up with new connective tissue of collagen and this thing we called extracellular matrix. And that's what gives the strength to the wound. So the wound contracts, builds this new tissue, it builds new blood vessels, which create all the nutrients and the oxygen go into the wound and creates healthy new granulation tissue, which is the good tissue that we want. So good granulation tissue, it's pink and red in color. We'll go into that later. What you don't want to see is dark granulation tissue. That can be a sign that there's not enough oxygen supply and there may be infection in the wound. All right. And then lastly, then we have the maturation phase, which is also known as the remodeling stage of wound healing. So this is when the collagen is remodeled, and this is where you get your strength to your wound. So it is quite thick and strong, and even though this new collagen is strong in comparison to areas which are uninjured skin, it generally only have about 80% of the tensile strength when fully healed in comparison to unwounded skin. So that wounded area will have less strength in comparison to unwounded areas after the healing phase. So next up then, so growing challenge to treat chronic wounds. So it's a global problem. Chronic wounds represent a silent epidemic that affects a large fraction of the world population and poses a major threat to public health. So the burden is growing rapidly. That's because we have an aging population. A lot of people are living older. There's going to be increased healthcare costs because we're going to have a lot more wounds. We're going to have a lot more chronic wounds. And as well as that, because it's an aging population, we're getting a sharp rise in incidence of other comorbidities such as diabetes and obesity. So just to mention the mortality rates as well, what you can see here, this was a mortality study that was done, and you can see that the risk of mortality when you have a neuropathic ulcer is actually higher of the risk when you have breast cancer or prostate cancer. And as well with an ischemic ulcer and peripheral arterial disease, the risk of mortality is higher than having colon cancer. So it's a factor when it comes to mortality rate as well, these chronic wounds. So things to remember outside the wound. So we have to take the whole of the patient into effect, not just the wound itself. So with our aging population, age is going to be a factor. When people age, their collagen decreases, it becomes less flexible and less elastic, and you're not getting a lot of oxygen to that collagen. So you're going to get a delay in proliferation, a delay in granulation tissue. So everything is a bit slower. Okay, then as well, if they're a smoker, it'll be issues. We have oxygenation and circulation there. If there's problems with peripheral vascular disease, peripheral arterial disease, microvascularization problems, if we don't get oxygen to that wound, we're not going to heal that wound. Because as we mentioned in the phases, collagen needs oxygen, and a lot of our white blood cells during the inflammatory phase, they need oxygen to work. So if we don't have the oxygen there, we're at nothing really trying to heal our wound. Stress is another factor, immune system, medications, if they're immunocompromised, nutritional status is a big one for patients. If they're malnourished, it's an awful burden on wounds, chronic illnesses, lifestyle factors, exercise. You could go on all day about all of the factors in that patient which can affect wound healing. Okay, so we'll focus on wound assessment then. So wound assessment, so accurate and timely wound assessment within a holistic patient assessment, so everything else that's going on in that patient, underpins effective clinical decision making. So it is pivotal to good wound management and should form the basis for wound care practice. Assessment enables appropriate clinical diagnosis and goal setting so that you know how to manage that wound. There's a plan in place. So the objectives of wound care. In the treatment of wounds, the clinician should endeavour to facilitate the following objectives. So the wound should be allowed to heal in a moist wound environment unless the clinical goal is to maintain a dry wound bed. So if it was an ischemic foot, to address the issues observed in the assessment process and to promote wound healing. So one way of doing this that we can is we use the time tool. So the time tool stands for tissue, it stands for infection and inflammation, moisture and edges. So you go through each of these stages to assess your wound. So we'll talk about these briefly now. So first up is tissue. Okay, so one of the first tissues you might see in a wound bed is necrotic tissue. So this is black tissue and it is dead. So it's non-viable tissue and we need to remove that dead tissue from the wound in order to progress on our wound and move through our wound phases. So how we remove it, if there's a numerous different products and things we can use. So enzymes, you can use mechanical, sharp debridement, autolytic debridement. So you're debriding that dead tissue away in order to progress. Next up then is sloughy tissue. So sloughy tissue is a yellow-green tissue and this is also dead tissue. So just like your necrotic tissue, you need to remove that tissue in order to progress to the next phase. You do it the exact same way, so your autolytic, your mechanical, your sharp debridement. And then after that slough is removed, the next goal would be managing exudating the wound and promoting the granulation tissue, which is underneath that slough. Next up then we have granulation tissue. So this is our red, healthy tissue. This is what we want to promote and we want to grow in our wound. So how we do that, numerous different products, exactly like the necrotic and slough. There's so many different ways of doing it, but the aim is just to promote that granulation tissue. So these wounds would be healing by secondary intention. So they would be a deficit in the wound and you want to grow that granulation tissue. And lastly, then we have the epithelializing tissue. So this is pink and this is healthy tissue. And these epithelial cells are leapfrogging over one another and they need to be moist in order to do that. So they go from the edges of the wound into the middle of the wound in order to cover that wound. So we just want to protect that and keep that wound nice and moist in order to do that. So that's our tissue. So next up then we have infection and inflammation. So this is where chronic wounds often get stalled in the phases of wound healing. So with infection, we have a scale. So we have contamination, colonization, critical colonization, which is otherwise known as local infection, and then infection, which is systemic infection. So as you move up this scale, you'll get increased signs in your wound and your healing rate of your wound will decrease. So just to move on to the next slide to show you further the signs. So contamination, every wound is contaminated, but the wound is fine. It might have a smell, it might be painful, there might be a small bit extra of exudate being produced from the wound, but the wound is healing. So everything is okay. That bacteria is there, it's not replicating, it's happy, and the wound is happy. But when you progress along the stages, your bacteria replicates, and then that's when the wound starts to stall and slow down. So with colonized wounds, you get increased signs of odor and pain and exudate, and the wound is beginning to slow down a bit now. And then you move on to localized infection. So this is critically colonized. Your wound is now infected. You have the same signs, but they're overt signs. We have spreading erythema, it's hot to touch, and the wound is now deteriorating. And what happens if we don't control the local infection is the patient will get sick and then they will be systemically sick. So then we'll have a temperature, raised white blood cells. In chronic wounds, you might not even see pyrexia. You might see that they're not eating, they're lethargic, other issues like that. So that's the surrounding tissue involvement and you have a very sick patient at that stage. So you can see very much from the inflammatory stage, as I mentioned in the phases of wound healing, that these signs are very similar. So you have pain, you have exudate, you have erythema spreading. It laps very much over with inflammation. So when you're thinking of infection, always think of inflammation at the same time with chronic wounds. So then moisture is M. So moisture, we have a number of things to discuss. So first up is colour with exudate. So you can have numerous different colours of exudate coming from a wound. You have your serous exudate, your purulent exudate, sour sensuous exudate, and your sanguineous exudate. So you have clear, pale exudate. You could have the thick, cloudy, yellow-green colour exudate. That would be a indicator that there's infection going on, and then you'd have bloody stained exudate that may be post-surgery or post-trauma, a removal of a difficult dressing of removal. And then you have the amount of exudate that you need to monitor. So a dry wound would have no exudate. Low exudate in a wound would be minimal amount on a dressing. Moderate exudate would be contained in the dressing, and high, the dressing would be saturated. So the exudate would not be contained. So a few things to look out for. Increased exudate can indicate increase in bacterial burden. Chronic wound exudate contains excessive proteases. So there's these proteases in chronic wounds, and they're very harmful to the wound. They start eating up that collagen that we want in order to progress the wound. So we always need to monitor our exudate in our chronic wounds. We want to watch out for small size wounds and copious amount of exudate as well. So lastly then, we have our edges. So the edges of the wound, a wound margin tends to change in appearance as the wound progresses or deteriorates. So we want to recognize and track these differences in appearance to age decision making. So an ideal wound edge, so it's attached to and it's flush with the wound bed. It's moist and it's open, and the epithelial rim is thin. It's often pale pink to translucent. So that's an ideal wound edge. What you don't want is a rolled or curled under closed wound edge. This is also known as epibole. So it can be dry, callous, and hyperkeratotic, so it's thickened. So it's a thickening of the epidermis, the outermost layer of the skin. It can be lighter in colour, and it has a raised, rounded appearance. And what has happened there is the top layer of the epithelial cells, which normally leapfrog over the wound to close the wound in the middle, is they haven't managed to leapfrog it. It might not be moist enough for them to do it. So they have met the epithelial cells at the base of that epidermis, and they now think that the wound is closed, so they're not going to move any further. So what you need to do is you might need to debride that wound edge or aggravate it with mechanical dressing in order to get them stimulated again and wake them up basically and tell them this wound isn't healed. Okay, so a few other things then with the edge of the wound is we need to look out for macerated skin. So this is changes in the skin resulting to moisture being trapped against the skin for a prolonged period. So the skin appears wrinkled, it's white, it's grey in colour. So we want to protect that skin. We don't want it to get macerated. So we'd often recommend to use a barrier product such as Cavalon. So you provide a barrier between the skin and that body fluid and exudate. So we'd often say as well, you need more frequent dressing changes. You need a more absorbent dressing so that exudate isn't sitting on the good skin. It's being absorbed up through that dressing and taken away from the wound. You might get excoriated wound edge as well. We'd recommend a barrier cream as well. Sometimes if it's very bad, you might need a topical steroid cream. And then you might get erythema or redness around your edge as well. Just like we said before, you need to take note of infection or inflammation, which may be chronic in certain chronic wounds. Okay, so that's our time. So we've gone through how to assess the wound. So we can see if we get delayed in any of these stages because of any of those factors, because of the tissue, the infection, the inflammation, the moisture, the exudate, it's going to delay our wound healing. So what we need to do is we need to maintain a moist wound environment, reduce our microbacterial burden on the wound. We need to lower those protease activities in our chronic wound. So that's in our exudate. We need to draw that exudate out so that the wound can progress. And that's how you get an optimal wound environment, and we can stimulate that wound healing again. Okay, so to mention then, what we would often recommend for chronic wounds is SNAP therapy system. So it's a single-use and disposable negative pressure wound therapy system. So some of you may know it, some of you may have never seen it before. It's a simple to use, easy to apply, and requires very little training. So it's portable, it's discreet, and it's non-invasive. It's off-the-shelf convenience, it's fully disposable, so single patient use, you'd use it once for a patient and then you dispose of it. There's increased access to it, and it's trying to bridge the gap between advanced wound dressings and negative pressure and having easy access for negative pressure in the community. So this is what the SNAP looks like. So you'll see there up at the very top, there's a SNAP therapy cartridge. And this is basically a canister which will hold all of the exudate that's in the wound in this canister. It's a 60 ml cartridge, and you can get a bigger cartridge, so there's a Snap Plus. There's a hydrocolloid dressing, so you can cut that to shape, and there's a blue primary foam dressing. So this blue foam, just like back therapy, if any of you are familiar with it, will sit in the wound and you cut it to shape, and what it does is it promotes the granulation in these wounds that are healing by secondary intention. So we also have a snap securing hydrocolloid, which is helpful for areas that are difficult to seal with the snap. And there's a cut to fit tubing. So you'll cut that tubing to length, which suits the patient. And the snap therapy cartridge sits into a snap therapy strap, and that can be attached to the patient's leg or the patient's arm, or there's a little clip on the back of it that can be attached to the belt as well. So what you need for one dressing change. So just to go through it again, you have the snap therapy cartridge, your dressing, your hydrocolloid ring if you need it, and your snap therapy strap. So where to use it and the indications for use. So it's available for use for acute and chronic wounds. So it would be traumatic wounds, dehisced wounds. If you had any ulcers or any surgically closed incisions, you could also use the snap therapy system. So how does it work? So just like I was explaining, you're going to draw those wound edges together. So it's going to contract the wound and promote granulation. So we're going to be in our proliferative phase. We're going to remove any infectious material that's in that wound and remove any of the exudate. So any of the proteases that are in that chronic wound exudate is going to be removed out through that foam into the tubing and into the snap therapy cartridge. So it's power source. There's no battery. It's not electrically powered. There's a spring mechanism, and that's how it operates. So you don't need to be worrying about plugging it in or changing the batteries. Exudate management, as I said, it can hold 60 mils or 150 mils, and it turns into a gel just to contain the exudate in the canister. So there's a visual indicator as well for the patient to know, and the public health nurse or the staff nurse to know when the unit is working and when it's not working. So it's silent in operation. Very lightweight, you can track your exudate levels on it, and it's easy to use as well. So it comes in different therapy options. So normally with negative pressure, the optimum pressure would be 125 that some of you might be familiar with. So we have that in the normal snap and the snap plus, but there is other pressures available. So if the patient was finding it too painful, or if there was anything exposed in the wound that you were worried about that you might want to reduce the pressure, there is options there for that as well. There's also different dressing sizes. So we have the 10 by 10, the 15 by 15, and we have a snap bridge dressing kit. So for patients like diabetic foot ulcers, where this wound would be on the sole of the foot, it'd be very uncomfortable and it wouldn't be great for the therapy or for the wound if that tubing port was on the sole of the foot. So we have a snap bridge dressing kit then. So there's a soft foam interface that will be underneath the foot, and the tubing will be at the front of the foot, just as an option. So just a few case studies then to run through that have used the snap therapy before. So this is a diabetic amputation wound. So a 62-year-old female, and they used the snap therapy system. She was diabetic, peripheral vascular disease and hypertension. And the patient achieved full granulation of the wound bed and soft tissue coverage over exposed bone after 4 weeks of the snap. And they did the dressings twice a week. And the wound was then closed with an advanced cellular matrix. So in conjunction of the two, the wound closed after 10 weeks of using the snap therapy. Next up then we have a heel pressure ulcer. So this is a 91-year-old female where they started the snap system. Comorbidities of hypertension and peripheral arterial disease. They're treated with the snap therapy system for 9 days, so only a total of 3 dressing changes, with an average application time of 6.3 minutes. And the outcome was complete closure of the wound after just 1 week of the snap therapy system. And lastly, then we have a diabetic foot wound. So an 88-year-old male started on the snap system, was a smoker, diabetic, hypertension, peripheral vascular disease, coronary artery disease, had a few things going on. And the patient was treated with snap for 3 weeks until full granulation of the wound bed. So wound closure was achieved 9 weeks post. This patient went on to have acellular dermal matrix as well with their snap therapy. So summary then, it's mechanically powered and portable, discreet, minimally invasive for the patient, continuous delivery of your negative pressure, single patient use, so off-the-shelf availability for the patient, and it's silent in operation as well. So next up then, we just have a quick video to play just to show you the application and what it looks like on a patient.
Begin by preparing the wound bed and peri-wound skin per institutional protocol. If necessary, apply a skin protectant to the skin surrounding the wound. Prior to application, the dressing can be trimmed and shaped to size to suit patient requirements. The dressing should be adhered to at least 1 centimetre of intact skin to maintain a proper seal. To begin application of the snap dressing, slowly peel away the release liner as you carefully place the snap dressing over the wound. Ensure the centre opening of the port is placed directly over the foam interface, and carefully apply the dressing over the wound. Smooth out the hydrocolloid dressing onto the skin and remove any small creases. Next, remove the side release liners one at a time and carefully press the rest of the hydrocolloid dressing to the skin. Use your hands to smooth out the dressing to ensure an airtight seal to the skin. It's often helpful to hold your warm hands over the dressing to allow the adhesive to properly adhere to the skin. Cut the tubing to the desired length, ensuring the cut is straight and not at an angle. Fully insert the tube fitting onto the tubing. Connect the snap therapy cartridge to the tube fitting using both hands. To activate the cartridge, press down on the activation key and pull it out. Reinsert and repeat as needed until an airtight seal is obtained and the red pressure discharge indicator is not visible in the pressure discharge window. The green visual indicator should remain stationary to verify that there are no air leaks and excess air is removed from the system. In addition, dressing will have a sucked down appearance and the dressing will also feel hard to the touch. The snap therapy cartridge can be secured to the leg, arm or belt with the snap therapy strap. Visually inspect snap therapy system at least every 8 hours. Reset the snap therapy cartridge when the red pressure discharge indicator is visible and the snap therapy cartridge is not full. Replace the snap therapy cartridge when the red pressure discharge indicator is visible and the snap therapy cartridge is full of exudate. Snap therapy is a discreet and portable option for patients.
Okay, so that's the end of the video and the end of the presentation. So thank you very much, and I hope it was beneficial now for everyone that was listening today.
Thank you, Ella. That was absolutely fantastic. Now, I've lost my vision. I've lost me. It's all right. As I said, no picture, all sound. I can only do a few questions, and we have a few questions as always. People find this subject absolutely riveting, and they have so many questions. But let me just say that we'll start with on what kind of wounds do you use the Duoderm dressing?
Okay, yeah, so Duoderm is a hydrocolloid, so it would be to protect and add moisture to a wound, okay. A hydrocolloid, yeah, but you'd often use it with vac, so maybe they were
that's what they were probably thinking
yes,
of, yeah.
Yes.
Is there a rep who calls out? Can we put up details of maybe add it to the slide if we're sending out information that a rep that calls to demonstrate the snap therapy?
Yes, yeah, there's different people across the region. So,
Okay.
but I'm the clinical specialist for Ireland, so I can help. I'll add my email to the end of it, and you can just contact.
Okay, that's fantastic. What is the cost of it?
I actually don't know that now off by hand, but I know it's covered by the medical card.
Brilliant. That was another question.
Yeah.
Is it covered by the GNS or LTI?
Yes. Yes.
And to wrap it up finally, is there a help time for clients using this product?
A helpline, is that what you said?
I'm presuming it's a line, yeah.
There is, so there's a 24-hour helpline just like VAC, and they can ring, and there's clinical and technical support 24 hours a day for them, yeah.
And the last but not least, can you cut down like you would do with a VAC, as in cut down dressings to cut size like you do with a VAC?
Yes, you can, of course. Yeah,
Okay.
yeah, for the snap, you can cut the foam to size. Now with the snap and the VAC, it's for smaller wounds. Oh, you're back.
There we are. It's a wonderful invention, this is.
So yes, you can, of course, cut it to size. Yeah, that should be
okay, and that's it. Listen, Ella, thank you so
Great.
much. That was absolutely fantastic.